hepatitis. So we'll discuss about phases of hepatitis, microscopic finding, epidemiology, serology, and lab finding. So the easy thing to remember is hepatitis can affect hepatocyte. It can damage hepatocyte, hepatitis virus. So AST, ALT will be elevated. What are the phases of acute viral hepatitis? These patients can have acute symptom like fever, painful hepatomegaly, liver will be enlarged, and patient will say they are not alcoholic, does not smoke. Their AST, ALT will be elevated. They can have atypical lymphocytosis too, especially in chronic hepatitis. What are the microscopic findings? Lymphocytic infiltration, especially chronic. They can have apoptosis of hepatocyte causing councilman bodies. Chronic hepatitis can progress to post-necrotic cirrhosis. What are the lab findings? So they can have elevated AST, ALT, but ALT is more specific for liver necrosis than AST. So ALT will be more high than AST. They can have mixed hyperbilirubinemia. They can have increased unconjugated plus conjugated bilirubinemia. So because it is mixed, so it can go into the stool and in the urine. So in the urine you will see urobilinogen and urine bilirubin. So next is hepatitis A. So common but preventable infection in traveler. Average incubation period is 30 days. It is an RNA virus. Transmission is fecal, oral, sexual, not transmitted by blood. Not transmitted by blood. So what is the pathogenesis? So virus will replicate in hepatocytes in high number, and when it replicates, it will cause destruction of hepatocyte, which will cause elevation in AST, ALT. It is shed in huge amount. Once it is shed in hepatocyte, it will go to the bile and excreted in the feces in high amount. So this is hepatitis A virus, RNA virus. So these patients will present with acute symptoms, fever, jaundice, right upper quadrant abdominal pain, nausea and vomiting, not able to digest anything. So initially in the acute phase, IgM antibody will be high, but later as infection improves, IgM antibody will be there. So because IgG antibody is formed, so there will be no carrier state. What about treatment? Passive immunization can be done from past exposure. Active immunity, protective antibody in 1 month will be formed. So let's say if there is a patient who is exposed to hepatitis A patient, you can give them immunoglobulin for post-exposure prophylaxis. Active immunity, they usually form protective antibody in 1 month. Next is hepatitis B virus, is very important virus. DNA virus, transmission is fecal, oral, sexual, blood, vertical transmission in pregnant patient, breastfeeding. So clinical signs and symptoms, they can have fever, nausea, vomiting, malaise, painful liver. They can have serum sickness, which include joint pain, rash, weakness, generalized weakness, aches and pain. So what are the complications? So fulminant hepatitis can happen if it is co-infected with hepatitis D, and then hepatocellular carcinoma can happen long term. Prevention and treatment: immunization with recombinant vaccine. If the infection is chronic, you can treat with alpha interferon alpha, lamivudine, and entecavir. So in hepatitis B virus, serology is most important. They will ask you about serology. That's the most important question they will ask. So number one is hepatitis B surface antigen, which is causing infection. This is the first marker of infection. So let's say you check the blood of the patient and hepatitis B surface antigen is positive. It indicates acute infection. It can present up to 4 months. It will be chronic. If it is positive and present for more than 6 months, then you say that the infection is chronic. But this is the first marker of infection in these patients. Hepatitis B surface antigen will be positive. What about hepatitis B E antigen? So hepatitis B E antigen indicate infectivity. If it is high, it means that patient can infect other people. It appears after surface antigen but disappear before surface antibody, before surface antigen appear. So it appear after hepatitis B surface antigen and disappear before hepatitis B surface antibody appear. Hepatitis B core antibody IgM remain positive in acute infection. It persists during the window period or serological gap. What is the serological gap? When hepatitis B surface antigen, hepatitis B virus DNA, hepatitis B E antigen are absent. At that time, you can check hepatitis B core antibody IgM will be positive. This is called window period, in which everything will be absent, only hepatitis B core antibody IgM will be positive. That's the window period. So this will be converted into hepatitis B core antibody IgG by 6 months. So by the time when hepatitis B surface antibody appear, this is the marker of protective antibody, or this is the marker of vaccination. So in vaccination, only hepatitis B surface antibody will be positive, no other marker will be positive. But in protective antibody, some other markers of hepatitis B infection will be positive. Chronic hepatitis B, if the surface antigen present for greater than 6 months, that is chronic hepatitis B. Healthy chronic carrier. So healthy chronic carrier have positive surface antigen and anti-hepatitis B core IgG will be positive. So surface antigen will be there, which indicate infection, but they also have anti-hepatitis B core IgG will be positive. So they do not have surface antibody, healthy chronic carrier. So the DNA will be absent and E antigen, which indicate infectivity, will also be absent. If it is infective chronic carrier, not healthy, then they will have E antigen will be positive and DNA will be there too. E antigen will be positive plus DNA will be there. Chronic carrier state increase the risk of hepatocellular carcinoma. So this is very important image, and it give you a pretty good idea about the understanding what is going on. So first marker of hepatitis B serology, hepatitis B surface antigen will appear, and that indicate infection from hepatitis B. So you are seeing that surface antigen will increase, go to peak, and then it will start dropping. Surface antigen is dropping. Now, if you test the patient at this level, between this, where surface antigen is gone and core antibody, so at this point only core antibody IgM will be positive, because surface antibody is not appear yet, and this is called window period. So during the window period, surface antigen is negative and only core antibody IgM is positive. So when core antibody IgM, so this is in blue, increasing, and that eventually it decreased too in blue. At that point, surface antibody appear, and that indicate immunity. Now let's say if hepatitis B surface antibody positive, rest of the things are completely negative, everything else is completely negative, that indicate vaccination. Now let's say hepatitis B surface antibody positive plus core antibody is also positive, IgG, IgM or IgG. That indicate that the patient had infection, but now get immune. Now they have immunity. So this is hepatitis B virus serology. It's very important. They will definitely ask you a question about serology in hepatitis B infection. So next is hepatitis C, RNA virus. Don't forget hepatitis B virus is DNA virus. A and C, RNA virus. Transmission by blood, IV drug use, needle stick injury. So most common chronic blood-borne infection in US, and third most common cause of acute hepatitis virus in US. Findings are similar to hepatitis acute, however it can become chronic. It is associated with type 1 mesenteroproliferative glomerulonephritis. It is also associated with cryoglobulinemia and B-cell lymphoma. Mesenteroproliferative glomerulonephritis we'll discuss when we discuss renal. Hepatitis C treatment, early treatment of acute infection with interferon. You can combine it with ribavirin and telaprevir. Complication, hepatocellular carcinoma. Hepatitis C virus, this is the core, this is RNA, and then outside E protein. So healthy liver, chronic hepatitis C infection resulting in chronic hepatitis, result in cirrhosis, convert into hepatocellular carcinoma. So what is the serology? So presence of hepatitis C virus IgG indicate active infection or recovery. Anti-hepatitis C virus IgG does not differentiate between acute, active, chronic, or resolved infection. How to confirm the test? do immunoblot assay and test hepatitis C virus RNA. This is a gold standard. It will give you an idea about viral load. So during the acute hepatitis C virus infection, anti-hepatitis C virus will be positive. Anti-hepatitis C virus serology, IgG, will be positive. IgM, if you do the PCR to detect the RNA, that will be positive too. And then if it is chronic, this will stay positive. Anti-hepatitis C virus antibody will stay positive. Next is hepatitis D virus. Incomplete RNA virus require hepatitis B surface antigen to replicate. Transmission is sexual and blood transmission. Chronic state is likely with hepatitis D virus. So hepatitis D virus can happen with hepatitis B virus co-infection, or it can happen. So both hepatitis B and hepatitis D can infect the liver. This is co-infection. Or sometimes there is an acute infection with hepatitis D on patient who has chronic hepatitis B. So that is basically a superimposed hepatitis D virus infection. So in that kind of situation, fulminant hepatitis can develop, liver failure. Hepatitis E virus, it can cause fulminant hepatitis in pregnant patient. It is very similar to hepatitis A virus, RNA virus, fecal oral in developing countries, but it can cause severe infection in pregnant women. So let's take 5-minute break here, and then we will discuss our next topic.